Thank you very much, Professor Bowen, for agreeing to answer a few questions on behalf of MDS patients in the UK. So to start off, could I please ask you to introduce yourself, just briefly, your role and where you work?
I'm Professor David Bowen. I work in Leeds Teaching Hospitals, and I've had a long-standing interest in MDS. I first started MDS work in 1987 as a research fellow, and I've been involved in MDS work and study and patient care ever since.
So as the first group of questions we'd like to put to you, they're about the benefits of support groups like MDS UK. Could you tell me a little bit about the typical issues you encounter when you first diagnose a patient with MDS?
I think the biggest challenge for a patient is that they had never heard of MDS in the first place. They wouldn't know any friends or relatives with the disease in most circumstances, and it's the unknown element that is a real problem. So the conversation that I normally have, I ask the patients how they are feeling, how the symptoms affect their life at any one time. Um, then we go on to try to explain what MDS is. I usually use the MDS patient support booklet to make the particular issues for that patient specific for them, and I mark the booklet with the sections that are relevant to them. Sometimes, if I think I'll find it helpful, we'll draw a cartoon of the MDS and the normal bone marrow and how that actually changes when MDS develops to try to help the patient to get an understanding of the disease. But I guess the first conversation that we have is about making it clear in my mind what the impact of the MDS is having on the patient's lives, and then trying to explain to them what MDS actually is. And then we go on, depending on how much they want to know, to develop conversations about what the likely prognosis is for the future for them and what treatment options we might have available to us.
What difference does it make to you personally in your daily consultations to have a well-informed or empowered patient? And what are the benefits or drawbacks?
Well, I think it's very helpful if the patient comes back and then they have a considerable amount of information, they have a better understanding, or indeed if they've got an inclination what the disease is in the first place, and they come with information pre-prepared. This is a disease of older patients generally, but not always, and so many older patients come with their younger family members who would probably be more familiar with the internet these days, and so they'll come with information that they've gleaned from the internet. One of the problems is that it's always important to glean the right information from the internet, and there can be issues related to some drugs that patients have seen on the internet that are for completely different diseases and are not relevant to them in the MDS context. But if they know something about what MDS is and they have some idea about the likely outcomes, and they come with a set of questions that they've developed from their own reading, then it is a useful framework to hang the details that are specific to them. The difficulty with MDS is that, like many diseases, it comes in a lot of flavours, and not really one MDS patient is the same as another. So we really have to try to personalise the treatment plan and even the diagnosis to the patient as much as possible. And so whilst we have a lot of tools, we have a lot of frameworks, at the end of the day, what we're trying to do is to gather those tools and those frameworks and condense them down so that our individual patient can be considered as an individual, and then a plan developed for that individual. And the problem with the information that's out there, whether it's just generally on the internet or whether it's from patient support groups, is that by definition it can only be generic. It can only really relate to the broad disease and not to the individual patient. And so it's a useful framework to come with all that information if you're a patient and you're a family, but the conversation develops from that starting point. So yes.
Now I'm going to ask you 4 questions regarding treatment and trials of patients. So, how important is it to have a treatment plan for MDS and why?
Well, it's very important to have an individualized plan, and the number of parameters that play into that are increasing all the time. So we have the patient's symptoms and establishing a plan for relieving those symptoms as much as possible. We want to establish what the goals of treatment are right from the start. So most of the plan is related to the goals of treatment. What are we trying to improve? In what way can we make the patient's life better or at least acceptable? And so the treatment plan is based upon the goals. But the factors that play into the treatment plan are the nature of the disease that they have, the very specific type of MDS that they have, and we're learning more and more about that all the time. Then there are the other diseases that affect the patient at the same time, and we're not so studied. Those are not so studied, but they are clearly major players in how we would approach the specific treatment and what the patient's expectations might be of the treatment. And then there are the treatments themselves and whether they are suitable for an individual patient, whether perhaps they might be too toxic under some circumstances, or they might be just simply not effective in that particular specific situation, whereas in other patients with MDS they might be effective. So we try to come up with a plan that's based upon a synthesis of all of that information, and we document that carefully then in letters, and we send the patient the copy of the letter that we send to the GP. And this is now becoming much more standard practice in the NHS generally. And that allows the patient to have a verbal understanding, them and their family, of what was discussed, and then hopefully a written document that they can use to reinforce that information.
So, how frequently do you discuss clinical trials with your MDS patients? Are there any current trials that you're discussing at the moment that are particularly interesting or promising?
Well, we are a major centre for MDS research, and we have been for a long time. So we're very focused on clinical trials here in Leeds. Most of our patients are suitable for at least a registry clinical trial, and the registry is essentially an opportunity to collect information about every patient's type of MDS, and to use that information then going forward and document the information about how those patients' MDS develops and what sort of treatment they have and what sort of response to treatment. So that is a trial, a registry trial, a prospective registry, and this is becoming really very important to generate data that we can call real-world data or community-based data. That is, to record the information about patients who are not in clinical trials of new drugs, but are nevertheless managed using conventional treatments. And we need to know what the outcome for patients in day-to-day practice is so that we can make a comparison between that and treatments that are developed in therapeutic trials. MDS is not a disease that is high up in the conscience of the pharmaceutical industry. However, there are a modicum of drugs that are being tested in clinical trials, and there is increasing interest particularly because of MDS in the high-risk setting and its parallels with acute myeloid leukemia. So there are many trials in that space now, and where they're available, we would consider patients for them. The problem is that many of the patients are just not suitable for clinical trials because the trial protocol specifies what type of patient needs to go into the trial, and very often that doesn't exactly match the patient that's sitting in front of you. So we have to be careful to match the trial to the patient, and then we would discuss trials in detail with them. But where they are available, we usually have the clinical trials available in Leeds, and we would usually ask patients to participate if they wish to.
What are the kind of difficulties that you encounter when explaining the concept of trials to patients? Do you have maybe examples of a really successful trial for a patient?
Well, we have a standard approach really to trying to instill in the patients the importance of clinical trials. We emphasise the possibility that the trial could benefit the patient, but that there is inevitably benefit for the wider community for the future if they participate in a clinical trial. We would be quite honest about what we knew about the product. Obviously, if the product has already, the investigational product has already had some trial exposure, we would say that yes, this is a promising drug. But the way I put it to patients is, because we're usually doing what we call phase 3 clinical trials, where we're testing the new drug against whatever is considered to be standard or a dummy, a placebo. I put it to the patients that the only way that we can assess whether the drug is effective is to work out whether it works, whether it does what we hope it would do, for example, improving the hemoglobin concentration in a patient who's anemic, whilst at the same time not having too many toxic effects. So the typical situation in that context of the phase 3 trials is that the drug has had modest exposure in terms of the numbers of patients, and it looks promising in terms of the fact that it works and it appears to be safe. But until you expose a lot more people to it, you don't know how effective it's going to be, nor how safe it's going to be. And so you need to explain that to the patient, that just because a drug looks as though it's going to be effective in the first instance, it does not necessarily mean to say that when larger numbers of patients are treated, that it will be both effective and safe. And therefore, testing it against a dummy drug is a logical thing to do. And so it is a difficult concept, and I think people are justifiably concerned about being allocated to the placebo, to the dummy drug. But we can try and reassure patients by saying that we just don't know whether the test drug is actually going to be better or not, and this is the only way that we can test it. And I have to say, most patients, when you give them a sensible explanation like that, understand the concept and usually participate, in fact. The other practical problems for MDS patients in terms of participating in clinical trials is the fact that many people are at the elderly end of the spectrum and are not so mobile, for example, and have other diseases affecting them as well. And so the practical aspects of clinical trials can be challenging, can be difficult for them to get to the trial centre. But there are ways of trying to overcome that as well. So, yes.
How do you address and explore quality of life issues with patients and their families?
Well, at the moment, in terms of quality of life, we don't have very good what we call instruments or tools that are available for routine practice. Now, this is a problem, and it's something that does need addressing as quickly as possible. At the end of the day, the quality of life actually is really the crux of the attempts to improve outcome in our patients. We're not going to be able to cure many patients with MDS. We simply don't have the drugs to be able to do that. So we are aiming to try and improve the survival of patients, so make them live longer. But we're most of all trying to improve the quality of life while they are surviving, hopefully longer. However, we don't have objective information that says if you fill in this questionnaire and you fill in another questionnaire, we have 6 months later after treatment, we've demonstrated that your quality of life is better. We don't have that information for routine practice. So we are left with asking the patients detailed questions about what they can and can't do, what they would like to be able to do, and then making a judgment as to whether we have achieved on their behalf, whether they have benefited by improving those symptoms. So, for example, with patients with anemia, if they can't walk up a gentle slope without getting short of breath because they're anemic, then after treatment with a drug that improves their anemia, they can walk up that slope, then that is considered an improvement in quality of life. But there is a real thrust of research ongoing at the moment. We have major research initiatives in Europe that are focusing on quality of life. There are instruments, as we call them, instruments developed now, questionnaire-based instruments developed, which we're validating in MDS patients, in a large number of patients. And we're looking at how useful they are to be able to predict the outcome of patients. And we're also looking at how useful they are in terms of measuring responses to drugs in a way that matters to the patients. It's easy for us to say we treat with a new drug and the hemoglobin value goes up, but if the patient doesn't get the benefit of that in their day-to-day life, that is not a useful treatment. So we have a number of initiatives where we're working on this within the European MDS Research Registry. We're proposing at the moment, we're planning a program to study blood transfusions in much more detail, focusing on the relevant outcomes for the patients and not so much just on the hemoglobin levels. So we're much more aware of this issue, and across the board in cancer management generally, there's much more focus now on patient-centered research that matters to the patients, and it's long overdue.
Now we'll move on to questions about second opinions, which are really important for patients who have a rarer disease like MDS. What are your views and your views on patients who request an additional opinion? How do you generally react? And does it actually offend you if people ask for a second opinion or an additional opinion?
I have a very open approach to practicing medicine. I feel very strongly that patients should have the opportunity to see a true expert in whatever disease they have. And I think that the reserved UK personality trait is one that doesn't naturally push for this kind of expertise. And I just find that concept quite difficult to understand, because that's not a concept that I would take forward if I had an illness. The fear of offending is obviously real, and that's a British personality trait. I don't think that that's really grounded in much real evidence. I would be surprised if a good caring doctor would be offended if a patient said they wanted to go and see somebody else for another opinion. I'm sure it happens, but it surprises me that does happen. I don't think patients should be really of that mindset. They should try to get an opinion from a specialist wherever possible. And that's part of the reason that we put into the national MDS guidelines that every patient should have an opportunity to see at least a regional or a national expert in MDS, because the disease is rare and because the science and the treatments are evolving quite rapidly. So I think now more than ever, patients should take the opportunity to see an expert and get second opinions if they feel that they would want more information. But I think the problem is that empowering the patients to do that is quite challenging. And of course, the MDS UK Patient Support Group attempts to empower patients effectively, but more by the patients coming to them than by them going out to every single MDS patient that's diagnosed. That's simply not practical. So I think we have to empower the clinical nurse specialists to try to encourage patients to get the maximum information that they can. And we have to find some way around the fact that our colleagues working in all the hospitals around the UK are so busy that it's very difficult for them to think about getting extra opinions. There is a a nihilism about MDS because there's been so few drugs historically. There's always been a nihilism saying that we all know how to treat MDS. We just give them blood transfusions and growth factors, and that's true to a certain extent, and I would accept that. But what the specialist can offer, what the expert can offer, is a detailed review of the specific context for that individual MDS patient, taking into account the advances in the biology of the disease, taking into account the experience of that MDS expert who will have seen a lot of patients over the years, and imparting much more information to the patient than is conceivable in the local hospitals, because there just isn't time for detailed conversations. So when I see a referral for a second opinion or a specialist opinion, I try to allocate at least about 40 minutes of my time to talk to patients in detail, and I try to make it quite clear that to them that the type of MDS that they have is what we're talking about. It's not a generic conversation, it's a very detailed conversation. So most of the patients that have that time commitment and that level of detail, I think they feel better for just having had that information. Usually nothing changes in terms of the treatment that we recommend, but at least they're empowered by information, and they can rest knowing that there is nothing else available for them. And we know that as specialists when we receive a referral, and the referring doctor knows that. But it's still reassuring for the patient if we can all come to that conclusion. So I have no problem with referrals, and I refer patients all the time for other opinions. I have a set of colleagues who I work with nationally and internationally, and if I have a difficult patient here, somebody I'm really not sure what the right thing to do is, I will often send an email to 5 or 6 of my international colleagues and say, I think this is the right approach, but I don't know, actually, I'm not sure. I have this nagging doubt in my mind. What do you think? And again, the patient, when I tell them, I'm consulting widely on this. I don't really know what the right thing to do is. It's not that I don't know what I'm doing, which is of course one of the fears that you might have when you're doing that kind of thing. It's that I just don't know what the right thing to do is, because there is no right thing to do based on the evidence. The evidence doesn't help us. So if you ask around your national and international colleagues, and you get a series of opinions, at least you can come to some sort of conclusion that's based upon an evidence group that is larger than just you making that decision individually. So, yeah.
What are the benefits to you as a haematologist when your patient is in a shared care setup at a MDS Center of Excellence?
Well, we as an MDS Center of Excellence, we share the care of many patients with the referring hospitals, and it usually works very well. So there are a number of circumstances in which we do that. For clinical trials, we have to see the patient to do all the trial-based assessments and give the investigational product. We have to see them in our centre, but they can receive all other care in their centre. So we share the care, for example, in patients who are on blood transfusions, and we're giving them treatments that may improve their blood transfusion. That has to work well because the trial depends on that interface working smoothly. And the clinical research nurses, the clinical research staff, are liaising constantly and with nurse specialists, as well as the doctors liaising with the doctors. So that's a well tried and tested. For patients that I see for sort of specialist opinions, we have some patients who like to come back repeatedly here and go back to their own hospital. And what they do then is we basically make sure that they're not duplicating efforts. So we make sure that they have a reasonable interval between the visits to their other hospital and to our hospital. We maybe see these patients every 6 months here, and then they're seen every 6 months in the local hospital. So there's a group of patients, generally the younger patients who could at some point be considered for transplantation, who we perhaps see intermittently in the specialist centre. We test their bone marrow intermittently, and we'll see them with the detailed results. Um, that's one example, and then there are others obviously who come because they just want to keep in touch with us as well as have all their practical care delivered locally. And as long as the written communication stream is good, and where necessary the verbal communication stream is good between the medical staff and the nurse specialists, then that all works very well.
Professor Bowen, where are we in terms of more personalized treatment for MDS?
Personalised treatment is personalised medicine, precision medicine is the buzzword at the moment. We've always practiced personalised medicine. Personalised medicine means that you sit down with an individual in front of you and you consider them as an individual, and you talk about their disease, their type of MDS, in the context of their problems, their symptoms. So it's always been personalised. And it's always been personalized in the sense that you are using your intuition and your experience to make a judgment about the appropriate management of that patient and the appropriate type of communication with that patient. So that's not new. What is new is the amount of data that we can generate about the biology of the MDS. And we're moving into an era now where we can get much more biological data about the patients. But to practice good, proper precision or personalized medicine, you need the biological data, you need an idea of the quality of life, you need an idea of the other diseases that are affecting that patient, and you need an idea about patient preference. So there are many factors now playing into the concept of personalized or precision medicine. The general view out there is that precision medicine is all about genomics. Well, it isn't. It's all about much more than genomics. And we will generate now big data. We'll generate big data sets, which include all of this type of information. And this is the way that healthcare is going now. The big companies, Google Health, IBM Watson, they're mining the internet for masses of information about patients and about diseases and trying to create these big data sets. But at the end of the day, you can have as big a data set, objective data set as you want, but you still will have to call upon intuition and experience to make final judgments, because they often play very strongly into the decision-making process, as does patient preference. And you can never presuppose the preference of a patient. As long as you give them the appropriate information and the appropriate options, the patient preference can never be assumed. So I think we are in the era of personalized medicine, but we're probably not exactly all talking the same language about personalized medicine yet.
In your opinion, should we start to insist that all MDS patients must have a genetic mutation test to establish what treatments may work out best for them?
So genomic medicine is very much the sort of happening field of cancer biology at the moment, and MDS is no exception. In fact, MDS has been leading the way because colleagues of ours published one of the very first what we call targeted sequencing papers in a cancer identifying a new mutation using this new technology that's available, about very powerful technology for interrogating all the genes now and identifying the new mutations. So we are moving rapidly forward in this field, and the problem now is not the ability to generate some data. The problem is actually interpreting the data that we have, in addition to trying to generate more data. So yes, we can tell from a set of mutations that we analyze which MDS patient has which mutations, but there are various technical reasons why one mutation may be relevant and the same gene mutated in another patient may not be actually causing the disease or problematic, or may not be present in a high enough quantity to be sure that that's actually relevant. So the more you know about this field, the more complex the analysis of the data becomes. And I think it's easy to take it all on face value and think that we know all the genes that are mutated in MDS, so we know a lot of the genes that are mutated in MDS, and therefore we now just need to work out for an individual patient which mutations they have, and it will tell us something new and helpful that we can use. Partly that's true, partly we can do that. We've identified some genes that confer a poorer prognosis, so the survival will be shorter if the patients have those genes. We don't know yet whether we can do anything about that, so we don't know. We don't have treatments that can necessarily reliably improve the survival if those abnormal genes are present. But we're working on that. We're looking back on large data sets to see if there are drugs that we have available now that can improve the outcome for people who have certain abnormal mutations in their bone marrow, in their MDS bone marrow. Whether every patient needs a genetic screen for routine management is debatable, but because there are relatively few drugs that we use that are actually able to target the mutations that we know are there. So if we have mutation X and we can use drug Y, we're not quite there yet. Some of us use the mutations mostly in terms of whether a patient should be transplanted or not, although we don't actually know whether that's the right approach. Many people don't use the mutation data because it's evolving. So I think we're in a phase where if you know a lot about it, on the one hand, you know what the limitations of the information are, but you also know the data, so you can give the patient some kind of feel for whether it's good or bad. But what's really important now is that we gather together very large data sets of MDS patients to be able to look at the complexity of the genetic changes, and they are very complex. So we're up probably now to about 140 genes that are known to be mutated in MDS, and would fit with a panel that we could use to identify the combinations in a large trial or research context, and the number is increasing all the time. And so at the moment, I'd say yes, it's nice to have a genetic test for all patients who have MDS, and we do here, but we don't always know what to do with it. We don't always tell the patients about it because it would only serve to confuse, and I would only tell the patients in detail about it if I thought that it actually influenced the discussion about the treatment and the prognosis, and that doesn't happen very often.
What would be the research benefit of collecting tissue samples from all MDS patients? And how can patients ensure this happens?
Research is always important. Without research, we don't make progress. There is now more of an acceptance that large data sets from routinely treated patients are just as valuable as the clinical trials that we do in parallel. And we're trying to collect genetic samples from all of our routine patients for research purposes, provided that we can link those to good quality information about how the patients fare over time and what treatments the patients get. So we have a big registry program here in Yorkshire and Humber, where we are doing mutation analysis on all MDS patients and following them over time from a population of about 3 million people. That will be a very valuable data source. In the European registry program, we're doing something similar from a large number of MDS patients and following them over time with a genetic profile done on their diagnostic samples. In terms of the research that's going on, we are now gathering very large data sets, large numbers of patients, bone marrow samples, and then trying to correlate that with outcome as well. So I think it is great if a patient can participate in this. All these initiatives are going to inform the way that we treat patients in the future, and if it is possible to have a bone marrow sample stored with appropriate ethical approval and consent, and this contribute to the big data sets that we're developing, that would be incredibly valuable from our perspective and hopefully rewarding from the patient's perspective, as they know they're contributing to a worthwhile initiative.